for the invitation and good morning. So I'm a physician specialized in imaging, molecular imaging. So I will give you the radiologist point of view about the needs and challenges for AI to be part of our routine, to be part of medicine and precision medicine. So I will first talk about CAD softwares and then about the next steps, more integrative softwares. So this software, computer-aided diagnosis, are systems that will assist doctors in the interpretation of medical images. It will help us and give us a second opinion, and they are already implemented in the PACS, but this is what is called narrow AI because it just can answer to a specific question, a specific problem. And there are different applications. I will give 3 applications for me. These are main applications: anatomical contouring, lesion detection, and lesion classification. So we begin to have these tools in our PACS. They are not so much used by the radiologists for now, and I will try to see what can make the difference between a success story and a failure story, something that would not be used by doctors. So what's the clinical issue? You know that there is an increased demand in imaging exams for patients. Nowadays, most of doctors do not only rely on their abdomen palpation or hearing the lungs. They often want an imaging exam to confirm the diagnosis. So we have a huge increase in the demand of exams, and we have also an increase in the amount of images per exam, because 15 years ago, a CT chest was about 40 images. Now it's 600 slices, because it's thinner slices. You have multiple reformatted images. You have multi-modalities images. So it's a really big issue that now for one exam, we have hundreds of slices. And do we have more time to see all these images? The answer is no. You know that there is financial problem for the hospital, and they ask us to see more and more exams, and the techniques gives us the opportunity to see more and more thin pathologic findings, but we do not have enough time to see all the images. And we see more, but we miss more. And this is where AI can help us, because it may help us to solve this issue of amount of images. I think there are 2 main ways that CAD can help the radiologists. The first way is the one that we are talking a lot about. It's time saving and efficiency, and a gain of efficiency for the radiologist. So this is important. This is most of the new CAD focusing on, but there is another aim that we must not forget, because for me it's the main things. It's to improve the quality of diagnosis, and I will try to show you how, to my point of view, it can be improved. So some examples of CAD applications. So the first one is anatomical delineation. When I was a resident, I began working on MRI images, and a big part of my work was to delineate the ventricular, left and right, and it could be a very, very long task, from 30 minutes to 50 minutes, and it was indeed quite important because it calculates the volume of the heart, the ejection fraction, so I have to spend time on this, but I think it was quite a low-value medical task that I could not give to another person because it was quite difficult, but it was very time-consuming. And 2 years earlier, I participated to a challenge, the MICAI challenge, and we make a big database with MRI images, and we ask developers to evaluate the different deep learning techniques, and the results were very good, because the correlation between the ground truth, my ground truth, and the machine was 0.997. So it was very good correlation, and these tools have been implemented in the PACS. It's really easy now for for radiologists to use these tools, and we gain a lot of time. So as said, Dr. Ashkar just before, it's very useful because it saves time, it gives us more time to analyze the images, to talk with the patients, to talk with the cardiologists, and also this is not very wahoo tools, it's very useful for us because we gain time. One other part is the detection of lesions. There are different parts of the radiologist's work, and the first part, mainly in oncology, this is my main field of interest, we have to find the lesion. So it's nearly like, where's Charlie? So we have to see, check for him. We are not sure that Charlie is here. So maybe it's funny when you do it for 10 minutes, but when you do it all your days, it's quite boring, and it's quite, I think, a low-value task for radiologists, because the next part is much more interesting. It's when we have found Charlie, we have to analyze him. Is it a good guy? Maybe a terrorist? And I have to put him in the context, and how can I manage him? And this is, I think, more the intellectual part of our job. So if AI can help us to detect the lesions, then we have more times to focus on interpreting the lesions, which is the high-value work. So one example of CAD for lesion detection, so we have talked a lot about lung nodules, and some solutions are nowadays now in our packs. We can use them. They're not so much used because there is a false positive rate, but I think it is improving now. But to find nodules, when you have patients with cancer, to find the lung nodules, it's a small part of our work. It's only 10% of the work. We also have to find other lesions, such lymph nodes. And for that, we have to go to the image and check all the lymph node area of all the body. So these are this round structure here. This is illness. These are tumors. And it is quite very long to find all these lesions. And AI could, I think, soon help us to detect all the lymph nodes, the pathological lymph nodes in the body. You also have metastases, and you have plenty of questions like this. So lung nodules, okay, but there is a lot of other findings where AI could help us. No. So this part of the task AI will increase our efficiency, and the needs are huge. But I told you that there is also a need to increase the quality of our interpretation, of our work. And how can you do this with AI? I think you have to find the weak points of the radiologist. Where is it bad at? Where does he fail? And there are medical errors. And for example, I will give you two examples. Bone lesions in the oncologic settings. So most of the time radiologists would check lung, liver, but bone, you have to change the sets of image, you have to change the windows, and they can be easily missed. So here it's an example, and you will see, so you have to change the window, change the image, and then check for lesion. So there is a little compensating lesion here, just here, up, it passed, here. So it's quite difficult to find, and I'm sure that AI could just segment all the skeleton and help us to find this white lesion, these condensated lesions. And we know that in the radiologist reports, there are lots of bone lesions that are missed, so it could improve the diagnosis. One other interesting example, it's about the complications. When you have a patient with cancer, one main complication is pulmonary embolism. It's something that occurs quite often, and it's very a poor thing for the patients because he can die of it. And when we are checking the images, most of the time we check the tumor lesions, but we forgot to check the complication and the pulmonary embolism. You see this, it's here in the arterial vessel, in the pulmonary arterial vessel. It's density, and if I have an algorithm that will check for the pulmonary artery and told me, okay, I think there is something, there is a lesion, there is a thrombus inside my artery, then it will be really helpful for the patient because most of the times we forgot to check this. So if the AI CAD do this, it will really improve the management of the patient, it will save life, and so this is what I think AI have to do to be complementary to the radiologist and to find the weak points so as to respond to this issue. Another thing is the classification of lesions. So when the radiologist, we are interpreting the exam, our response is often a probability. It's neither black nor white. It's rather multiple shade of grays, only in the colorway, I mean. And I think AA could help us because our interpretation rely about our knowledge and experience. And in most of cases, the radiologist is not an expert in the field, or it can be a young radiologist. And AA, by comparing your image to a vast data set, can give this experience, can say, yes, this is probably an adenocarcinoma because I have a data set and it looks like adenocarcinoma in my data set. It will give the experience to non-experts or to young radiologists. So this must be very useful. There is a huge potential indication for this, but I think what's an important point is the identification of normal exams. This is not very sexy application, but this might be very useful because I told you that there is a huge increase in the prescription of imaging, and most of the time it's just to eliminate a disease, an illness. So we have big piles of exams, and it's quite a low-value task because most of them are normal, and it increases the risk to miss the pathological findings in one patient, in the only patient that was ill. So a great challenge for AI developers, I think, will be to have to classify normal images. But to do this, your algorithms have to eliminate all the abnormal things. I mean, it has to eliminate infections, nodules, pleural effusions, and then it say, okay, I'm sure this is completely normal, so check this one because this one there is an abnormalities. I don't know what is abnormal, but the radiologist will focus on this patient. So I think normal images is a main need. The key points for development of CAD in imaging, I think you have to answer the question, does my solution match with a medical need? It seems quite obvious, but I think doctors and AI developers have to work together. In the biology fields, researcher knows very well that, and so we collaborate because they have very interesting questions, but sometimes we know that they won't lead to things that we can use in our routine. So I think it's the the same thing with you, with the developers in AI. We have to talk together to help us to find the good question to respond to a real need. The second thing is that you have to consider the workflow of radiologists. How is the workflow, and how a youth solution might fit inside this workflow? Because radiologists, we are quite impatient, so we have workflow that are designed, and if your solution is many clicks, or if not the good question in the right workflow, then they will just not use it. So it's very important to know what our workflow looks like and how your solution can fit inside. The third key points is the database. I know that you want very big database with thousands and thousands and thousands of patients, but mine's the pitfall, because if it's very big, maybe there is a lot of heterogeneity inside this database. The heterogeneity can be in many ways. It can be in the demographics of your population, it can be in the staging of the lesion, in the type of lesions, in the machines, because machines do not give the same type of image, size of voxel, resolution, and this can introduce some big bias. And even acquisition, we have different protocol among the clinical centers. So if you have big database, you might have a lot of heterogeneity, and knows where are the heterogeneity, because you will have to answer if your algorithm can respond to this problem. Another thing is that you have to be aware that expert database that we'll find do not always reflect the reality. Expert, it's in big hospital, and if you develop an algorithm on an expert database, you have to be sure that it can apply to the real world and to general hospital. For example, I met a surgeon, a very important surgeon, who is very good at operating carcinomatosis. It's quite difficult, and with 3 other experts, he has made a database, and he said, yes, I've done an algorithm that can predict if the surgery will succeed or fail. Okay, it might be very interesting, but is it useful? Because it's the prediction for him, for the expert, but if you want to use it in other hospital, general hospital, maybe the solution will not give the right answer. So when you have a database, you have to know where does it come from and take care from the database expert, which can be very useful but quite dangerous for the next step. So this was CAD, and the other tools are more advanced or comprehensive intelligent system that will predict patient's outcome. We, as physicians, we all want to know the patient's futures. Will he respond to the treatment? Will he have toxicities? And this is a very big point, because if we know that, we can anticipate the disease and treat it better. So this is the next step in the area of precision medicine. We all talk of precision medicine. It's most about biology. So we find the molecular abnormalities and we find a drug that targets it. But the next step will be to integrate everything through AI for precision medicine. I'll give the example of a multidisciplinary tumor board. So the physicians gather together and we take the treatment decision for the patients. It's about 30 and 40 patients in 2 or 3 hours. And so we have about 2 or 3 minutes per patient to take the decision. So how can we manage this? We use evidence-based medicine and we use biomarkers, but really few parameters to decide. Most of the time in oncology, it's less than 10 markers. It's the patient age, the tumor size, some biological characteristics. But the problem is we know that the reality is much more complex, that there are we have now huge data with genomics and other biology, with imaging, with clinical records, and we have to integrate them together, because giving the same treatment, the same sequential treatment for all patients is not the good solution in oncology. And AI could help us, what we cannot do during a multidisciplinary board, to integrate all the data. AI could help us to do it by giving the solution very easily and quickly. So I think integrating imaging, biology, patient records will be an important challenge for treatment decision. For these predictive algorithms that may be very useful, there are some challenges, I think. The first is the clinical validation, because with the CAD, it will be quite easy to validate them. The radiologists, can see the results. We see if the anatomical contour is good. We see if the nodules detected was a tumor nodule, so we can check it. Do not matter if it's a black box, because we can check the results. With predictive algorithms, we cannot be sure of the answer. He would say, yes, this patient will respond in the next few months, but when we take the decision, we don't know if the solution is good. So here, I think the radiologists will quite fear the black box, and it might be a challenge. The other thing is that we have to perform multicentric validation. It is quite complicated because we do not work in the same way in the different hospitals. We do not have the same protocols. And this is the important job for physicians, to build prospective, multicentric studies with good quality data, and then to work with you with this database. But this is very challenging. Then there is all the regulatory things, but I will not go on these things. The second point is the ethics. we should not forget that the patient's point of view is very important, and we have to explain them why we are doing this, how we will do this, and what will be the impact for them. You know that the patient give us the data, they are at the center, and they give us the data, they sign a consentment, but it's not precise that it's for AI. So it will be, they give us because they rely, they have trust in the physicians. So it's very important for the next step that to imply the patients and even the lab and the companies, I think, have to talk with the patients' associations to make them be part of it and to avoid a big scandal problem in the media that could be very harmful for us. And the third point is that most of our database are quite small databases. So you want a lot of data, a lot of patients, but we will not succeed in many clinical issues because some pathologies, some diseases are quite rare, and we have 100 or 200 patients, but we will never have more. So this challenge is on your side, because we have to give solution for this patient, even if the disease is rare, and you have to develop algorithm that can deal with small data sets and predict the patient on small data, the evolution on small database. So thank you. So this was only about imaging, but I think the whole chain for patient management will change from diagnostic to therapeutic and to monitoring the response. So this is a big deal for us, and I think we have a lot of work and we have to work together. Thank you very much.